tell us a little bit about how long you've been a physical therapist and sort of what your training was first.
Yeah, so I've been a physical therapist for almost 5 years now, if you include the time that I was on my student rotations and everything. So the schooling was about 3 years. I did a combined undergraduate and graduate program at Duquesne University. And yeah, I've been practicing in a general outpatient orthopedic setting for about 5 years now.
Okay.
So yeah.
And what percent of your patients would you say are, sports related? Like I came and saw you as a CrossFit athlete. I use athlete loosely.
Sure.
Workers' comp, which of course is the bulk of my practice area, and maybe like car wrecks, which I've also seen you as a car wreck victim.
Yeah. Yep. So I would say those are probably some of the big main three payer mixes that we'll see. So I would say it kind of varies between like a commercial insurance set. So, anything from post-ops to kind of general aches, pains, and strains from either sports or overused postures, repetitive injuries, those kinds of things. Workers' comp, so obviously injured workers. And that can sort of range in a lot of the same kinds of categories from minor aches, pains, and strains to post-ops, and then car accident victims would probably be the third biggest subset of payers that we see as well.
Okay.
And then you get kind of all the diversity within those three camps as well.
Yeah, tell me, what do you think are the most common injuries you see in your practice?
Yeah, so it's kind of hard to specify by any one particular injury, but I would say some of the more common joint or body areas that we see affected are going to be lumbar spine, cervical spine, shoulder, and knee. Those would say that's probably the biggest four kind of general areas or regions that we'll see.
Yeah. That's funny. When people ask me what are the most common injuries I see in my practice, it's pretty much the same. I say back, shoulder, knee. I'm not as specific as what you just said, but
yeah. Well, I mean, I think with the lumbar spine, it's something statistically, it's like 8 out of every 10 people is going to experience some episode of lower back pain at some point in their life. It's like 80 to 90% incidence rates of some degree of lower back pain at some point throughout the lifespan.
Yeah. And so you said you see folks for workers' comp and if car wreck, I'm sure personal injury. What are some ways you're asked to help with that, like giving causation? Do you ever have to do that, for instance?
No, not really. So a lot of the times our records could get like deposition for the cases themselves or something, but really all we're focused on is helping whatever client we see in front of us get better with whatever their issues are day to day from a musculoskeletal perspective.
Okay.
So a lot of the times, like we'll document a little bit of like a mechanism of injury for what happened. Patient was involved in motor vehicle accident on blah 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 and is now reporting pain, stiffness, tightness, whatever the symptoms be. In any whatever given areas, and then we just kind of treat it like any other case where we're trying to get the person back to whatever they need to be doing day to day.
Yeah, sure. Okay. And do you ever do functional capacity evaluations?
I used to.
Okay.
So I used to do functional capacity evaluations. It's been a little while that I've done them. But yeah, so that's sort of as an injured worker is getting towards the end of their case, or if they're looking to close things out, from what I understand, they'll usually refer for a kind of an ultimate functional capacity evaluation to determine where their MMI is going to be, essentially.
Yeah, I see it, like you said, to determine if they're maximum medical improvement or MMI. They call them FCEs, and my clients will tell me like, oh, I've been sent to, scheduled this test. What does this mean? And I don't know if you did this, but most places they'll hook them up to a heart rate monitor to try to gauge their effort, and I think pain level too. Your heart rate goes up if you're hurting.
Yep. Yeah.
And have them kind of do a workout for 3 or 4 hours or longer. Some of them are all day.
Pretty much, yeah. So it's and it can range. And they take a look at a lot of functional different types of activities. So there's a couple of different, the ones that I would perform, there are a couple of the different lifting tests, static pushing and pulling, dynamic pushing and pulling. And then they have a whole section on movement-based tests, so like walking laps, a couple balance things, timing how long you can carry something back and forth over a distance of 10 meters or something like that. But yeah, and then kind of like you were saying, taking heart rates and pain measurements all the way throughout to try to determine like a consistent and reliable effort of what this person is available to do.
Yeah. So what advice would you get for someone who's about to have an FCE to prepare for it, especially if they've been out of work for 6-9 months and aren't used to exercising?
Yeah, for sure. Well, absolutely. I would say give it the best effort that you possibly can. There's going to be instructions from whatever therapist that you're trying to get evaluated by to kind of help to meet that goal. But I think the biggest thing with an FCE is a consistent and reliable effort. So as much as you can do that, then the rest should kind of take care of itself.
Sure. Would you recommend a patient tell you like, hey, this is hurting me?
Absolutely, yeah, because those are all things that the therapist should be able to document as you're going through an FCE. So if you're feeling any kind of pain with any of the movements, any kind of discomfort or exertion effort, anything like that you feel like could be a good subjective note to make a comment on, let your evaluating therapist know, and they should be able to at least reflect that as you're going through the test in the notes.
Yeah. What other advice would you have for someone who comes to you for just physical therapy, not an FCE, on, treatment and sort of how to handle that, or how seriously to take it, those types of things?
Yeah, I would say biggest things are, I would say keeping an open mind. So a lot of the times it's not always everybody's first intuition to exercise when they're in pain. But a lot of the times the therapist is going to be able to tailor whatever exercise program that they think would be beneficial for you given whatever current status you have. But at the same time, there is going to be a couple of moments where you might have a little bit of discomfort, or you might have to try something new that might be a little scary, depending on what your issue is and what your level of comfort with activity is. But I would say keeping an open mind, asking questions, and then being involved and engaged in your own care as well. I would say those are some of the biggest things to help you and your therapist be able to work together over the course of your care.
Sure. And when you say be involved in your own care, are you talking doing exercises at home, or what does that mean?
Yeah, so that could be doing exercises at home. Typically a therapist will give you some sort of home exercise program to be working on as well. But also just having a little bit of a general idea about how your overall symptoms are progressing, and kind of being able to have a couple tools to keep that in mind as you're going through your care as well. So a lot of times we'll ask questions like, is it better, is it worse? So that way we're trying to gauge a response to any one particular activity in relation to the progression of the care as a whole as well.
Okay. What is the difference between heat and cold? And of course, I've been treating with you after a car wreck I had in December, and sometimes we'll end by doing an ice pack over my wrist, and sometimes we'll do heat. So kind of what's the difference in when those work?
Yeah, so ice and heat, they can be really nice therapeutic enhancers, I guess you could call them. So using ice or heat in isolation of anything else typically isn't going to get you any kind of physiologic healing on any kind of cellular level. There are a couple benefits that you can get from either one. So they'll say, for example, heat is usually really good for improving blood flow. So it's a vasodilator, so you get a lot of blood flow into an area when you put heat on it. And it's a tissue relaxer, so it makes things a little bit looser, a little bit more malleable in terms of you could follow it up with a massage or a stretch, and that can be kind of a friendly way to help prime a tissue for some sort of other type of intervention. And then ice, they say, is typically going to be a vasoconstrictor, so it's going to reduce blood flow into a specific area, which can be really nice for things like swelling and inflammation control, like a post-exercise soreness, or like a burning type of a sensation a lot of the time. Really, you could use either one. There are specific times you would not want to use either one. But for the most part, they're going to be really nice therapeutic enhancers.
Okay. Yeah, you said to help maybe after, or to bring swelling down. So is that why you see athletes doing like an ice bath or something, which looks miserable to me? But
yeah. A lot of times it's going to be more of for like a post-exercise burning or like a soreness type of a sensation. They say that an ice bath can really kind of help to cut down on the amount of time that you can be sore after a workout.
Okay. What about stretching? Is that something that's important to do before or after a physical therapy session?
I would say stretching to a point, but not necessarily like a dedicated, like I just need to go stretch my hamstring 3 times for 30 seconds right before an activity. So I would say a more broad application of that topic would be like a warm up and a cool down pre and post activity. Okay. And I think just keeping in mind that you can transition yourself into a more active state and transition yourself more out of an active state as well. So if you're an office worker who's sitting 10 hours a day and then you go run a marathon right after going from sitting to running a marathon, your body might have to take a little bit more of a time to adjust to whatever you're doing versus if you're able to maybe go for a short walk before you run or something like that.
Sure. I assume that's why I see a lot of people in physical therapy with you doing some warm up on the either treadmill bike or arm bike. Is that what we call that?
Yeah.
I do, or the regular
fancy name would be the UBE, the upper body ergometer. But yeah.
Okay.
Yep.
Or if they have knee or lower extremity, I'm assuming they're walking on the treadmill, of course, to sort of warm their body up a little bit before doing exercise.
Yep. Yeah, and then so just like you said, I'll usually typically use that for like a little bit of a warm up. But also, that's usually a pretty friendly, self-guided way for people to kind of get used to movement again, especially in an instance where it might otherwise be mentally hesitating to be involved in movement. So that's a really nice, low impact type of way to just kind of help get somebody used to moving again if they haven't for a while.
Sure. What are some types of injuries where you've seen PT help someone avoid surgery? Like for myself, I have a slap tear in my left shoulder. I did PT a few months and haven't had to have surgery.
Yeah.
It's basically gotten better to about 98%. So shoulder, I guess, is one. Are there others?
Shoulder is one. I would say meniscus issues in the knee is another really big one. There are a couple of different kinds of surgery that they can do for that, but a lot of the research is trending towards giving it a really full effort with a physical therapy program, and a lot of the times you can either prevent or delay a surgery in the longer run. So a knee meniscus would be a good one. Disc issues in the spine a lot of the times, as long as it's not an emergent type of a scenario. A lot of the times physical therapy can also be a really good way to help prevent and or delay a surgery in the long run for any kind of lumbar spine issues. And then the kind of the cool thing too is even if surgery is the ultimate goal, a lot of surgeons are actually referring for what they call prehab now too. So a lot of surgeons, even if surgery is the ultimate goal, a lot of surgeons are starting to refer for a course of physical therapy before the surgery, with the idea being that if you can improve your baseline strength and range of motion measurements, that typically your recovery on the back end of a surgery is going to be a little bit easier as well.
Okay.
So there's all different kinds of scenarios where you can either prevent or delay a surgery, or sometimes you can improve your baseline stats before having a surgery, and that typically will make your outcomes a little bit better on the back end.
Okay. So being more athletic and fit helps you get through surgery more successfully? Is that fair to say?
Typically. I mean, and it kind of makes sense too. Whatever your status going into a surgery is the idea is that's kind of going to be about your starting point coming out of it. So if you can improve where your starting point is before the surgery, the idea is that it'll make your recovery on the back end a little bit easier.
Sure.
Yeah. And that can look like all different kinds of things. It doesn't necessarily have to be like a CrossFit type of an athlete going into a surgery. That could even be somebody that's an office worker that just wants to get a little bit more active before their issue or before their surgery, so that they can have a little bit of an easier time with their recovery on the back end.
Okay.
Yeah.
And when you say recovery on the back end, are you talking about physical therapy post-surgery?
Physical therapy post-surgery, and then even just, sometimes having an idea about what being in a sling is going to be like. So a lot of times, like a course of prehab could involve like wearing a sling a couple times and trying some day-to-day activities before the surgery. That way you can kind of get used to moving and functioning in a little bit of a different status. If there are any sort of precautions associated with the surgery, a lot of the times you can sort of practice doing activities within those precautions as well. So one of the things that I saw when I was out at Travis Air Force Base was they would do a total joint replacement class for people that were about to undergo total hips or total knee replacements. So they would have like an education session a couple times a week that was sort of open to anybody that was about to have that surgery, so that they could come in and learn a little bit more about it. And a lot of times a lot of people would say sort of anecdotally that would make a lot of their tasks after the surgery a little bit easier as well.
Okay.
Yeah.
And you said a word a while ago, something about an emergent. Are you talking about a disc in your back leaking fluid? Is that what you mean by like a herniated disc?
Yeah, and I mean, like every injury, there are some that are going to be a little bit more on the emergent side. So like if you have to go to the hospital right away after some sort of accident or issue, if there's any sort of like, with the disc issue in particular, if there's any sort of neurologic compromise, a lot of the times like even kind of simple bodily functions can become compromised in those types of scenarios. So as long as it's not something where a physician on the more acute side of the injury determines that it's something that needs to be addressed sooner rather than later, a lot of the times in those instances, physical therapy can be something that's helpful.
Okay.
Yeah.
Have you ever had your deposition taken?
I've
for
not.
a case? Okay.
Nope.
Yeah, I think orthopedic surgeons get deposed a lot, but maybe not physical therapists.
I think it depends. I did have one surgeon call me about an impairment rating that I had done. He thought that the method that I used was wrong, but that was about the only thing that I had in terms of like a disagreement about something that I had written.
Oh, funny.
Yeah.
Well, I know in Georgia we're using the AMA Guide to Impairment 5th edition.
Mm-hmm.
So I guess they tell you which guide to use, because are we on the 6th or 7th now?
I think the most recent one is 6, okay. But as long as you cite whichever one you're using, I don't think anybody is going to, because the 6th edition there are some changes, especially to spinal impairment ratings. I think they're using the DME more than like the range of motion method. I think is one of the bigger switches that they were starting to get to, as I was getting out of it at least. But as long as you document whichever method you're using and somebody can go back and kind of follow your steps, then it should be fine unless they're looking for something in particular, which you would typically know that on the front end.
Right. Yeah, I guess it just depends on why it's being done. I know some states use the 6th, Georgia uses the 5th. My understanding is the 5th is more advantageous for the injured worker who's getting the percentage disability.
Liberal. Yeah, sure.
And the higher the percentage, the more their permanent partial disability rating is going to be, at least in the workers' comp context. But how's the process normally for figuring out that PT is not going to help you avoid surgery, right? Like, is that a call you make with the doctor? Or?
A lot of times so we do, especially for workers' comp cases, and it depends. Each representation company has their own specific documentation guidelines, but as a majority, what we would do is we would do an initial evaluation, and then every 2 weeks or every 6 visits, whichever comes first, we would do a progress note. So let's say it's a shoulder issue, and we take your shoulder range of motion measurements at your very first day. We get 2 weeks into our program, and we take your shoulder range of motion measurements again. Obviously, if we see good progress, then I think we can kind of safely say that things are trending upwards and that things are getting better. If we either see limited or no progress, or if things are getting worse over time, that's something that we'll have documented that the referring physician can then use as information to make a decision one way or the other from that point. So as a physical therapist, we're typically not involved in making decisions about this person's care overall moving forward, like in an ultimate sense, but we can certainly help provide information as a means to that end for the referring physician.
Yeah, sure. So you have relationships with, I assume, a lot of orthopedic surgeons that they refer to you and you refer to them? Or?
Yeah, so we work closely with a lot of different groups. A lot of the times in workers' comp cases, they're going to be a little bit, I don't want to say limited, but they have choices about where they can go. So a lot of the times it'll be sort of the same with physical therapy. But as soon as we do get a referral, we stay in communication with the referring physician as much as we can. They will typically have our contact information, we'll have theirs. And then we kind of communicate through the patient back and forth as well. So if they go back for a follow-up visit, we'll ask them how it went and vice versa. And then we can always follow up with each other by phone, fax, or email if we need to after that as well.
Okay.
Yeah.
And how long does a typical physical therapy treatment regimen last? I assume the older you are, the longer it takes.
It depends, yeah. To a point, I would say on average, most people complete a course of care within 12 to 24 appointments. I would say that would sort of be your biggest end of the bell curve.
Okay.
Or like your area of the middle of the bell curve. But certainly there are some people that go a lot longer than that, and then there are certainly some people that either figure out that PT isn't going to be right for them, or something else happens and they only complete 1 or 2 sessions. On average, though, I would say about 12 to 24 is where most people will kind of live.
Okay.
Yeah.
What are some differences in physical therapy and, say, like chiropractic care?
So I would say a little bit more philosophy behind treatment. I would say both are really excellent for any one given issue. It just kind of depends on what's going to resonate more with the patient. So in general, I would say chiropractors probably have a little bit more autonomy in terms of what all they can do in terms of services rendered. So like they can order images, they can see people without a referral from a physician. So in terms of like a point of access, chiropractors have a little bit better systems for entry for patients a lot of the times because they can do a lot of the services that PTs can't. But I would say where PTs really thrive is following up the hands-on and the manual therapy with some sort of corrective exercise program as well. So a lot of the time, one of the draws about chiropractics is, you'll go a couple times a week to get an adjustment and it'll feel a little bit better, but you kind of have to do that regularly to maintain that progress, whereas with physical therapy, we'll do a lot of those same types of techniques and then follow it up with some sort of exercise program to help maintain the effects a lot longer. Is one of the general principles. Now, there are some chiropractics that do that really well and actually have people follow it up with movement and exercise. And then on the flip side of that, there are some PTs that just have people come in for manual therapy, and then that's their plan of care moving forward. So there is a little bit of overlap between the two. But I would say in general, PTs are going to be a little bit more widely versed in a lot of different types of movement patterns and postures, and are going to be a little bit better at integrating the whole movement system of a person in relation to their one specific issue.
Okay.